Bring the meeting to order. Thank you all for being here. Staff, thank you. Committee, thank you. Conferees, thank you so much for being here. And we'll start out with Steve Anderson. Very good, Steve. Thank you.
Thank you, Chairman Carpenter. I appreciate the opportunity to be here in committee. They say you should be careful what you ask for, you might get it. You guys asked for a presentation from my office about Medicaid, so that's what I'm going to do. Obviously, we love to take questions, so we'll see how it goes. So hopefully, yep, slides are up. There we go. There's the disclaimer the lawyers make us put in our presentations. And here's a little bit about our office. We're basically part of the, we're an independent division of the Inspector General's office, and we have statewide jurisdiction to look at audits, investigations, and reviews of the Medicaid program, which includes CanCare, as well as Medican, as well as CHIP. Our complete investigations are referred for prosecution. And I also have the opportunity to testify every quarter in front of the Bob Bethel Committee, which I guess some of you people will be members of. Here's a little bit about me, because I have a long career. I've got over 30 years in doing this type of work. I'm a certified inspector general, and I've worked at a lot of different places. Some people may think I can't hold a job, but that's not true. I worked with Air Force OSI back in 1989. I was with the GSA Inspector General's office doing contract fraud investigations. Then I was with the U.S. Department of Education IG's office doing education fraud, and there's quite a bit of that. Then I moved over to Labor IG's office and worked there. And then finally I came to the Attorney General's office in 2016, where I did Medicaid fraud investigations for them. And then in April of 2021, I became the Medicaid Inspector General, and I've been there ever since. The mission statements there and the vision, I'm not going to go through all that, but some of our goals basically is to detect, prevent, and deter fraud, waste, and abuse. That's really what it's all about. And we want to save the taxpayers' money. You might be asking yourself, what exactly does an Inspector General's office do? Well, we provide independent and objective oversight. Our investigations people want to do the prevention, detection, and investigate fraud, waste, and abuse. Our auditors look to do the promotion of promoting effectiveness and economy and efficiency and integrity of the program, and that's what auditors do. We also want you to understand that our office is free from political influence, which means that even though I work for the Attorney General's office, we are in no way take direction from the Attorney General. We take direction from the Bethel Committee and other people, but we are not told what to audit or what not to audit, what to investigate or not to investigate by the Attorney General or other politicians. So that's part of our statute for us to be independent. Also, confidentiality is a real important thing. You can rest assured if somebody makes a referral to us, we will keep that information confidential unless we have written approval from them to release that information. And that's really key, because a whistleblower, last thing they want to do is have their information plastered out there, and it's very awkward for them. I'd like to stick a slide with Ben Franklin in there to talk about how old fraud is. It's not a new concept. It's not something that was just invented in the past week or two. So Ben Franklin said there's no kind of dishonesty to which otherwise good people more easily and frequently fall than that of defrauding the government, and I believe that's true. Here's some information about common Medicaid fraud schemes that we see a lot. Phantom patients, I talk about this with Medicaid. Medicaid beneficiaries do not get an EOB, an explanation of benefits. So it's really easy for a corrupt Medicaid practitioner, and I'll talk about providers later, to bill Medicaid for services, and you would have no way as the Medicaid recipient of knowing that that's happened because you don't get that EOB. For most of us, if we have insurance like through Blue Cross or Aetna or anything like that, you're going to get something that says, hey, you had an x-ray on this day or you saw the doctor on this day. That doesn't happen for Medicaid recipients. So it's really easy for doctors to bill for phantom patients. They can also bill for goods and services not provided. We also have some providers who bill 8 days a week, 26 hours a day, which is really incredible that they're able to do that. But it does happen. A lot of unnecessary tests go on. We saw that a lot, particularly during COVID. Kickbacks happen. Concealing ownership in related companies. That's a situation where a doctor maybe owns half of a nursing home or a hospice and makes recommendations. Hey, you should go to this nursing home. They're the best. They need to tell you that they actually own half of it or all of it, and that they have a relationship where they benefit financially from it. Otherwise, that's a problem. Double billing happens a lot, and then we have false income and eligibility information for people who just flat out lie about their income so they can qualify for Medicaid and as well as food assistance. Sharing your Medicaid ID, we see that a lot in certain communities where people will, their neighbor, they don't have insurance. Well, here, your child looks kind of like my child. Here, take their Medicaid beneficiary card and go and get penicillin or have dental work, whatever you need, using their Medicaid ID. And then just flat out altering records. So who commits fraud? Well, essentially everyone does, but that's the punchline on the slide. But anybody who has an opportunity to touch the money could commit to fraud. And what is fraud? Well, fraud is an intentional distortion of the truth, an attempt to obtain something of value. It doesn't have to be cash. We've certainly seen other opportunities where people have gotten favors. It's maybe a vacation, maybe it's tickets to a Royals game. Well, you know, a hot ticket this weekend would be a Super Bowl ticket, right? So that would induce somebody to maybe commit fraud, but in layman's terms, it's basically lying, cheating, and stealing. What is waste? Well, waste is essentially just overutilization of a product or a resource, and waste happens a lot. I frequently use the example of having a teenage son living at home, and teenage sons waste, right? They leave the lights on, they use all your hot water, they eat all your food, they're wasters. Abuse, that's basically improper use of materials. It can also be somebody who uses their position to get things that are not authorized to have. So that's an example of abuse. Medical ID theft is a really important one for us. That's the misappropriation or misuse or appropriation of a patient or a provider's, and that's key. Unique medical identifying information obtained service or a bill for goods. And we see that a lot where somebody will steal a doctor's MPI number or their information. We see it a lot with the durable medical goods. You may hear about it a lot in Medicare, where somebody will get that and they'll bill it to a doctor or say that this doctor signed off on it when in fact that's not true. There's actually a federal statute that prevents or that punishes that for doing that sort of stuff. Where do we get our allegations from? Well, they come from the hotline, from other Medicaid program offices, FMS companies, private citizens a lot. We get those when somebody gets mad at you, they usually will call us. Spouses who are getting ready to go through a custody hearing or divorce court will want to call up and tell us all the bad things that the other person did, and then want to know if we can't come and arrest the person right before the hearing. They have motives, obviously, for doing that. Competing vendors, of course, who come from other state attorneys, other OAG offices, and state and local law enforcement. We have an active hotline ourselves. We also get an awful lot of things to the DCF hotline. I'll talk about it more later, but we get over 1,400 complaints a year involving mostly eligibility fraud. Here's some of the providers I was talking about. Of course, medical doctors, dentists, but also hospitals, nursing homes, pharmacies, durable medical goods, mental health clinics, transportation companies, ambulance companies can do all that, drug and alcohol treatment. Basically, anyone who touches Medicaid or has the ability to bill Medicaid can get into this. How do we select our audits? Well, they come from suggestions. They can come from bodies like this. We also have information that comes from Medicaid contractors as well as other offices. We look at the news and media. We'll sometimes see that something's happened in another state, and it's like, hey, we need to look at that. Hospice is one of those things we're seeing a lot of. And we also discover issues when we're doing audits. We'll also oftentimes find, well, there's 2 or 3 other things now that we need to audit because we found it during an audit. And what are the results of those audits? When we complete an audit, and I'll talk about our audits here in a minute, but we make recommendations, suggestions for improving quality and efficiency. We identify money that could be recouped. We don't have the ability to force recoupment, but we can recommend recoupment happens. It can lead to investigations that could lead to prosecutions. We also can identify, like I said, additional audits, and we issue interim reports sometimes if it's appropriate. We issued one last year involving school background investigations. The good news is sometimes we can confirm that the agency that we're auditing is actually doing a great job, and what they're doing is wonderful, and it's a best practice. And that's the upside. That's what you hope for sometimes. So let me get into some of the audit reports. We did an audit of a lot of these are going to be with KDHE, but we did an audit involving Medicaid claims that have been paid for beneficiaries on Medican that had exceeded the 12-month limit. Medican has a hard 12-month limit on it. You cannot go past 12 months lifetime. And we found out that there were 912 beneficiaries who'd been on the program, exceeded that, and that's all state general fund. That's not KMAP. There's no federal match. And so that ended up in $1.6 million being wasted there. But as a result of our review, we identified a bunch of other people, 556 people who were still on that were exceeded the limit, and KDHE immediately started removing them, which resulted in us saving $1.2 million for the state of Kansas. That was all state general funds. We then did an audit involving the capitations for deceased people, and we looked at that, and we found that there were a bunch of beneficiaries who had been dead. Some have been dead for as long as 5 years, and the MCOs were still getting capitation payments for that. As a result of our audit, the state was able to get back $1.3 million from the MCOs, because that is one example where they will claw money back, is that this person has died. So that was a good thing for that to happen. We did an audit of the HCBS program, that's Home and Community-Based Services. And what we found there were over 2,000 people who were enrolled in a waiver but had not had any kind of service at all for a 12-month period or greater. Some people had gone for as much as the 40-month period of the audit and never had a single service. Why is that important? You're required to have at least one service to be on a Medicaid waiver. If you don't, you're supposed to be kicked off the waiver. And because obviously you don't need the services if you're not getting the services. It's one of those things. And certainly you may have gaps where somebody may have a change of doctor or something, but for you to go for a year with 0 services, that's kind of unusual. And we found that $193 million was paid out to the MCOs as part of that. And we said we need to really look at that and consider how we can get that money back. But KDHE has a 3-month look-back period and would not go back and look at that and quote any of that money back. One of the other things we found in there is that they were doing the Life Alert bracelet, and we found there were 560 beneficiaries who that was the only service they got was Life Alert. And we paid out over $8 million for that. If that same service had been done through fee-for-service, it would have cost $55,000 to have done that. So we paid over $8 million to the MCOs for services, for Life Alert bracelets that could have been paid fee-for-service for a lot less money. Then we did a eligibility determination audit, and we found out that the state did not have good protocols and things in place to use the Paris report, which is a matching system that the states all enter their Medicaid and food assistance program into, and they find people who have benefits in multiple states. We've had people sometimes that had benefits from 5 or 6 states. But it typically will tip off if you have them doing that. So we found out that they didn't have really good protocols for that situation. And we were able to identify people who needed to be discontinued, and they did, and it saved $1.3 million doing that. And then the TransMed program, and that is a transitional Medicaid program, and that is for people who are transitioning from being on Medicaid into the workplace. And it's a federally mandated program. I think it's a good one. They have a 12-month limit on that as well. And what we discovered were there were over 2,000 beneficiaries who were on that, way past that, so we ended up paying out over $16 million in capitation payments for those people that were not eligible to receive that and should have been removed. We did a follow-up after that to see how well the KDHE was doing with removing people, and we found there were 580 people of those beneficiaries were still active as TransMed members, so they weren't doing a very good job of kicking people off. But we got them to go ahead and work on that, and ended up in a savings of $1.5 million for doing that. And then the last audit I want to talk about is the continuing care retirement community and continuing care provider. That was a case where facilities were basically taking advantage of the quality assessment, otherwise known as a bed tax. And the interesting thing about it is if you get charged at the higher rate, it's $4,908, whereas if you have the reduced rate, it's $818. As you might see, that's a big difference. That's over $4,000. And facilities that if you're a small facility, fewer than 46 beds, you automatically qualify for the lower amount. If you have high Medicaid volume, you also qualify for it. Or if you're designated as a CCRC, that's how you get that lower amount. What we found was that a lot of them, 68% of them, had problems and were not in compliance with the rules and regulations required to get that status. And consequently, we had lost revenue to the QCA fund of $87 million. We looked a little further and found that a lot of these facilities had absolutely no continuing care. They were strictly nursing home facilities. You have to have assisted living or some other thing on your campus that shows that you have a continuum of care available. And as a result of our work, we made recommendations for legislative change. It was approved last year, and it was moved from the Department of Insurance to KDADS, and is better located for them to look at things. And the good news is, because of that change, we've already seen facilities that were improperly being categorized as CCRCs, and they're not. That means they're going to pay the higher bed tax, which is going to end up saving the state of Kansas about $12 million every year going forward. And that is state general funds. That's not half or partial federal, partial state. That's 100% state general fund. So that's a pretty good thing, for a good win for us. Complaints-wise, in calendar year 2024, we processed 1,454 complaints. 1,318 of those involved eligibility fraud. Others 22 were non-eligibility, 76 involved providers or contractors, 1 involved a state agency, and another involved a state employee. 36 did not involve Medicaid and referred to the correct agency. Investigations-wise, in calendar year 2024, we opened 105 investigations and identified $236,000 in savings and recoveries. That was basically because of our investigation getting started. We identified these people were improperly on Medicaid. We got them off. We also recovered money that was being embezzled by a durable power of attorney for an individual in a nursing home. She had received an inheritance. The DPOA tried to steal the money, and we were able to recover those funds and get them positive back with the state of Kansas, so they paid for that person's Medicaid coverage, which is what's supposed to happen under state recovery. And with that, I'd be more than happy to answer questions, and my contact information's there as well.
Thank you, Steve. Committee questions? Representative McDonald.
Thank you, Mr. Chair. I was just curious how many employees you have. What's your FTE, and are they year-round, full-time, part-time?
Yep. We have a total of 10 employees. 1 is a part-time investigative assistant. My operating budget is just a pinch over $1 million this year. We have a request in to get additional staffing, because we feel like with as big as the program is, we could definitely use more people.
Follow-up.
Yes.
What was, I'm sorry, I interrupted. What is your request this year? I haven't kept up.
We put in, it's through the budget committee, we'd requested 3 additional FTEs.
Representative Blex.
Thank you, Mr. Chair. Thank you for your presentation. What percentage of clawback do we get from once you find there's a fraud? Do you find that then that responsibility for retrieving that money, is that on the state agencies such as KDHE, or just how's that handled, and what kind of percentages do we get back from your tables? You know, multi-millions of dollars worth of fraud, and are we getting any of that back?
We get some of it back, like I pointed out, like the $1.3 million for the deceased people, and then where we identified, like with the CCRCs, where we're not going to get money back, but we are in a position where we're saving money because we stopped the flow. We cannot retrieve money ourselves. It's up to the state agency to do it. They're the ones who have the authority to do it, and we can't force them to do it. We can merely suggest that they do so.
What kind of percentages do you see with state agencies? I mean, I got a choice I can save money by not going to Walmart. Mm-hmm. I mean, that's not a viable option for me. I mean, I think we need to, have some clawback from these state agencies. Are they doing their job?
Well, some of it's with the contract, but yes, some of it is the state agency doesn't desire to do the clawback. KDHE has a rule in place, for example, where they only do a 3-month look back for recoupments on some things, and that is something that might want to look at.
Okay. Thank you for that. Thank you, Mr. Chair.
Committee, further questions? Representative Oropesa. You may.
Thank you, Mr. Chair. Thank you for your presentation. So following up with Representative Blex's comments, have you seen state agencies not retrieve the clawback for years, or is this something more recent? Do you have a timeline? Has it always been this way?
I've been with the office since 2021, and it's been that way ever since I've been with the office.
Okay, and then my second question is there something that states that Medicaid recipients do not get an EOB?
Are you asking, are there some states that? where
No. Is there something in the state of Kansas that says that we don't do it, or it's just not done?
It's not in the contracts with the MCOs requiring them to do it.
Okay, thank you.
Representative Weichel.
Thank you, Mr. Chairman. I have two questions, if I may. My first question is regarding the couple of slides you had about people who had extended their time limit on Medicaid. I think one of those you said you published the audit in 2023 and the other one in 2021. Do you know what time period those audits covered?
They do. It may not be in the slide, but I can get that information for you. If you're talking about COVID, we intentionally did the audit period where COVID was not an issue.
So it was not during the continuous coverage provision during the public health emergency? Okay. And then my second question is, it seems like a lot of what you've talked about is payments, monthly capitated payments by the managed care organizations when somebody is no longer eligible or has deceased or moved out of state. What are your thoughts on if we just had fee-for-service instead of managed care and how that would change the dynamic here?
Well, I appreciate the question, but I'm not going to get into policy, things like that. But, you know, the state of Kansas used to be a fee-for-service and moved to managed care, and that's a decision for somebody beside myself.
Representative Bueller.
Thank you, Mr. Chair. I'm going back to whatever slide number is, when we're talking about when we moved the registration process from the Department of Insurance to KDADS last year. I remember that bill. I don't remember I don't want to call it a financial windfall, but did you expect that $12 million, I guess where it says an estimated $12,274,000 would be saved on the fiscal year based on the nursing home facilities being properly assessed at correct bed debt. Was that part of the bill last year? I don't remember that.
It wouldn't have been part of the bill, but it was in a report that accompanied the bill that was helped driving that. We reported out on that last year.
Okay. Because what I remember was an administrative change, and it made more sense to go to KDADS, but I don't remember that being a part of it. But
it was part of it because KDADS is properly applying the rules, and we anticipated if these facilities were properly categorized, because we had identified in our audit report that they were not properly categorized, and after they were properly, it would end up saving us $12 million.
Okay, thank you. Thank you, Mr. Chair.
Committee, further questions? Representative Rivas.
Yeah, thank you very much for your presentation. My question is, as Inspector General, how much authority do you have to bring criminal charges, or do you refer those? Have there been charges brought against some of these people? There's some levels of fraud here that seem like they should have.
Yes, we have criminal investigators in my office now. A year and a half ago, we had none. Nobody was doing eligibility fraud investigations at all in the state of Kansas. We got 2 special agents and analysts to do that. That's part of my request for additional staff, is to allow us to do more, because we could easily open another 200 investigations a year for that. But we work within the Attorney General's office. We can make referrals to the county attorney or the DA for criminal prosecution. We've certainly done that. We have attorneys within the AG's office who will prosecute our cases. We also have the civil matters that we're looking at, pursuing providers for civil fraud charges as well.
Follow up?
Yes.
Okay, so if you do find situations for these charges, do the agencies all cooperate fully, or do some agencies discourage the charges going forward?
No, sorry, I appreciate the question. The cooperation with KDHE and KDADS has been stellar. They're very supportive when we ask for support for criminal investigations.
Thank you.
Any further questions? Representative Bryce.
Thank you, Mr. Chairman. Thank you, Mr. Anderson. I was wondering about I appreciate a lot of the comments that have been made. They answer my questions. The fraud, as far as people sharing Medicaid cards. That strikes something with me because I've seen that. I actually know a fellow who got his knee replaced on someone else's Medicaid card, and patients I've had that have switched Medicaid cards in order to see me. And when I tried to think of how to counter that, about the only thing I can think of is some kind of biometrics. Is there anything been looked at as far as biometrics for Medicaid recipients?
I'm personally not aware of any thing for that, but you're right. The Medicaid card has your name on it, but no picture, like a driver's license would have a picture on it. So that doesn't exist. But I'm not sure. I'm not aware of anything that's being done to enhance the quality of it. It's not unlike the EBT card issue. Has the same set of problems.
Any further questions? Seeing none, Steve, thank you for being here.
Thank you, sir.
Very good. Next, we have presentation on the community mental health systems. The first conferee is Kyle Kessler. Kyle, welcome to committee.
Thank you, Mr. Chairman, members of the committee. I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We appreciate very much the opportunity to be here and provide kind of an overview of the Kansas mental health system and the CMHC system, and as part of that, the transformation we're seeing to the Certified Community Behavioral Health Clinic model as well. And I'll get into more of a presentation. I have to say that being accustomed to consolidating my testimony in 3 minutes in front of a budget committee or 3 minutes in a hearing where there's 30 conferees, 6 or 8 minutes almost seems like an eternity, and hopefully it won't feel like an eternity for you. But I think that for us as a system, we represent, as I mentioned, all 26 licensed CMHCs around the state. 23 of those 26 are 501c3 private not-for-profit organizations, and 3 are parts of county government. Those being Johnson County, ComCare in Sedgwick County, and then Crawford County Mental Health out of Pittsburgh. And so the system is one of shared governance, is the simplest way of saying it. Each county designates a mental health center. Either one county might designate a mental health center, and a mental health center might be designated by multiple counties. In Northwest Kansas, there's a mental health center that has 20 counties that it serves. So I think that for us, that county connection, as well as being licensed by the state, and now with the CCBHC model, also having the federal government involved as well. And then our system also works with multiple state agencies. Again, licensing being through the Kansas Department for Aging and Disability Services, certainly work with Medicaid and KDHE, and as well as DCF, the Department of Corrections, the State Department of Education, and now there's also mental health money in the Department of Agriculture's budget. So we have a lot of government in our lives. And so I think that for us to be very aware of policy at the community level is extremely important, as well as the priorities of the county commission, several of whom of you have served on those, and then working with our state policymakers and the legislature, and then paying particularly close attention to what is happening at the federal level as well. It's very important for us. And so instead of speed reading through our testimony in the 7 pages that we have shared, I will hit some key points on CMHCs and then the CCBHC system, and then turn it over to a couple much more adept individuals than I am on the history and the actual operational pieces of running a CMHC or CCBHC. And the mental health centers are required by the Mental Health Reform Act of 1990 to provide behavioral health treatment and services to any person, regardless of their ability to pay. We are essentially the gatekeeper for the state mental health hospitals. I know you all, especially if those of you who serve on Social Services Budget Committee, have been involved in state mental health hospital hearings in the last couple of weeks, and you are aware that there's a new mental health facility coming online in Wichita, July of 2027, I think. So January 2027, I apologize. And that can't happen soon enough. I think that the waiting list today for Osawatomie State Hospital is about 40. that means we hope that someone can stay well enough for the next about 7 days until they're able to get into the state hospital, which is the safety net for people with mental health issues and acute mental health conditions. So when that 50 beds comes online in Wichita, assuming that a large number of those who are on the waiting list are from the south central part of the state, and that has been, I would say, at best an imposition, but for people in south central Kansas, either you go 2.5 hours, which isn't an easy drive to Osawatomie, or you go to 2.5 hours, which isn't an easy drive to Larned. So I think having a facility down there, and for what they want that to be in terms of a teaching facility, will be a very good thing for our state. And so I might talk or briefly about the statutory authority that on the second page of our presentation, if you happen to be following along, it talks about Chapter 19, Chapter 39, 59, and 65. And so again, Chapter 59 being key to our relationships with the state mental health hospitals as the gatekeepers, and involved in the admissions and discharge planning pieces of that process. And then Chapter 39 gets into more of the mental health reform that I had mentioned previously. And so I think for us, the overarching goal is to keep people in the least restrictive settings as possible. So if we can catch folks when they are suffering from more moderate or even mild mental health symptoms before it really escalates, that is our goal. That's the best thing for not just the patient, but the family, the community, and the state taxpayers as well. So on the third page of our map, or I'm sorry, the third page of our comments gets into a couple things. One is the map of the overall state with all of the CMHC catchment areas. And again, our state's pretty unique in the way there are probably 10 or a dozen states that really have that county-based mental health system connection, and then ours with the state as well, and then some again, single county mental health centers, and some that serve 12, 14, 20 counties is pretty significant. I think that we also tie our systems goals and mission to Article 7, Section 1 of the state's constitution, which actually requires the state to foster and support facilities for persons with mental illness. And so I'm paraphrasing there a little bit, but I think that for us, having that connection to the constitutional requirements, and then also some of the discussion that you'll hear shortly from my colleague and some speakers on the Kansas Behavioral Health Center of Excellence and the workforce initiative that we have going there. This is something that we realized probably 6-7 years ago, that we were in a lot of trouble as a state, partly because we'd just been decertified by the federal government at Osawatomie State Hospital, which reduced our beds. We had 2 states close to us, which as part of the Excellence in Mental Health Act that was passed not quite now 10 years ago, but probably 7 or 8. Missouri and Oklahoma were demonstration states in that. So they very quickly realized that those mental health centers in Kansas train and recruit quality folks. And now we can pay $15,000 or more to have people come across the state line and work for us in Oklahoma or Missouri. And so it was really a perfect storm for us, I think, as a state, and funding had really dried up. We'd seen stagnation and cuts to mental health reform grants, as well as no increases in Medicaid rates for well over a decade, close to 2 decades. And so us needing to reconfigure or really reform our system was very, very important. So in 2021, after looking at the CCBHC model in other states around us, other states also around us having Medicaid expansion, we decided to start working on implementing our own CCBHC model. So think an amped up reimbursement system, but also equally, if not more, an amped up service delivery system and requirements related to those parts of being a CCBHC. So what that meant was that we wanted to have the legislature play a key role in designing that system. I would say as co-architects, our association and really the Kansas Mental Health Coalition as well, we're I think, key players in getting recommendations out of not just the Bob Bethel Cane Care Oversight Committee, but also Legislative Budget Committee, the Child Welfare Oversight Committee, as well as the Legislative Budget Committee. So it was something that was widely studied and discussed, and then we ran legislation in the following year, which passed both chambers overwhelmingly. And so that was a key victory, I think, for our system, for our state, and has now been the subject of model legislation in 4 or 5 other states, including Montana, West Virginia, Nebraska, and I'm missing one, Alaska, I think. And so there are others that started looking at this before the federal government then opened back up the opportunity to be demonstration states. And the first time that opportunity was available, we had missed it. And we're extremely disappointed by that. That's when we started looking at trying to model our system after what might be Kansas values and really putting a Kansas signature on it. And so then we were able to apply and be accepted into the demonstration with the CCBHC and the Substance Abuse and Mental Health Services Administration at federal HHS, and that just started July 1 of this year. So I think it's not an understatement to say that it represents the biggest transformation of the system since mental health reform in 1990. So that's now we're 35 years later after mental health reform, and there are just a handful of people around who actually worked on that, Representative Helgerson being a key. And I had talked with him about that a couple of years ago, and he'd made a comment that he wrote that bill, and I thought he was just being colloquial. And then I went back and started researching, and sure enough, his name was on the actual bill in 1990. I'm like, he did write that bill, and Governor Hayden signed it. And so I think for us, knowing that that is really the future piece of our system, and I want to conclude my comments by talking very briefly about the accountability that you all require and we embrace as being an important part of this system succeeding going forward. And certainly Chairman Carpenter has been insistent, it's probably a fair way of saying it, on us pursuing a way to share our outcomes, and whether those are successes or failures or whatever that perception might be, we need to know what it is taxpayers are getting for their money. And are we getting better at this, or are we failing? If we're failing, why? And so the investment is significant enough that we have absolutely agreed to that. And we're in the process right now of implementing a data warehouse that will be live across all 26 mental health centers. And I should have mentioned that to this point, originally there were 9 mental health centers in the first year that were certified, went through the certification process in, I think, 2022, 23, and then another 9 the following year, and then 8 just this last year. So now all 26 mental health centers are licensed CCBHCs and either fully or provisionally licensed. So with that, I hope that in the next 6 to 12 months, we have all of the mental health centers in this data warehouse. In the meantime, KDADS had commissioned a study, and I make mention of it in the last paragraph on page 6 of our comments. And the recent report commissioned by KDADS looking at the value analysis of CCBHC by the McKinsey Consulting Group in Kansas found that implementation of the CCBHC may increase costs by 40%. As compared to the original CMHC system, but increases access by 75%. We believe this is a substantial return on investment and is an early indicator of success in terms of broadening access. There are several things, again, I don't want to read them to you, but even on page 5, we go into talking more about the additional services that are required, with there being 9 core services required of all CCBHCs, and an additional 4 services that will be required by KDADs as evidence-based practices. Some of that includes things that you would assume, like medication-assisted treatment for people who are addicted to substance use or alcoholism, but even some of the things like supported employment services to get people back into our workforce and to allow them to pursue employment and hopefully get themselves off of Medicaid. I mean, we truly are one of the systems that has a goal. In fact, I'd say in some ways, like the child welfare system, we hope to work ourselves out of business at some point. Now, we don't ever have a chance of doing that, I don't think, as there's more awareness related to behavioral health treatment needs, and you have a pandemic, you have wars, and I mean, so veterans outreach is one of the required services of the CCBHC model, and I think it's really helped us, and people after me will visit some more. But with that, I would say I would conclude my comments and stand for questions at the appropriate time, Mr. Chairman. And certainly, you have Greg Hinnon and Tim DeWeese after me who will speak. And I think between the two of them, they've got 55 or 60 years of experience in the system, in the CMHC system in Kansas. And now, as I think back, it probably makes them sound like I'm calling them old, which I regret, since they're my bosses. But hopefully, they won't see it that way. But I'll stand for questions at the appropriate time.
Committee questions of Kyle. You're off the hook.
Very good.
I could grill
Thank
him,
you, Chairman.
I could grill him for an hour or better.
You have. Yeah, thank you.
I have. Thank you. Next, we have Tim. Welcome to committee.
Thank you. Thank you, Chairman, Board. I appreciate the opportunity to speak before you today. I can't overstate the significance of the CCBHC legislation in 2021 that this body moved forward with. It was visionary in nature, and it clearly set a vision for the community mental health system in Kansas moving forward. I've been the director at Johnson County Mental Health Center now for 10 years. I've worked at Johnson County Mental Health Center for nearly 30 years. So I've grown up within the organization that I now get to lead. And I see that CCBHC opportunity present us a lot of options to be able to serve people. So prior to us becoming a CCBHC, I had roughly 340 employees. Today, I have 486. We served just under 10,000 county residents prior to becoming a CCBHC. Last year, in 2024, we served over 18,000. We provided before the CCBHC and 988, which is another piece of work that we've done with KDADs and followed the direction from this body. We took 20,000 crisis calls. Last year alone, we took 41,000 calls, and I suspect that we'll be well over 50,000 calls this year and add text and chat capabilities to our ability to do that. We have seen an investment in our staff. So when we look at our turnover rate prior to CCBHC, it was roughly 27%. This year, 2024, it was 15.6%. And we see our vacancy rate reduced from roughly 10% to under 6%. All of this I share with you to say, again, when I say that the legislation that you all passed in 2021 to create the CCBHC system, unique across the United States, it was integral to providing services to our community, ensuring that individuals who need access to care have access to care, and that when we provide that care, we actually contain costs. And so the last thing that I'll mention is that another role within CCBHCs is to work with the crisis systems. to assess the community's needs and work with first responders to be able to early engage people within those services. So the diagram that I have provided you in my testimony basically shows you a list of services, what we call our crisis continuum of care. It goes from the least intrusive, least expensive service to the most intrusive, most expensive services. And what CCBHCs have done is allowed us to be able to fill in those gaps early on to be more preventative so that we can provide services to individuals when they need them. For example, co-responders. That's where we pair licensed mental health professionals with police officers. We have 21 co-responders in Johnson County now. We have a mobile crisis team that when there's not a co-responder available, that mobile crisis team can be mobily dispatched to that location. So when we talk about providing early access to services, that's what we're able to do, and that's what we mean by that. And through that access and then providing quality care, we see cost containment across entire systems. And I think that will only continue to play itself out as we're able to build the data warehouse and be able to share with you those specific outcomes. I will stand for questions at the most appropriate time.
Very good. Thank you. Committee questions. Representative Steens.
And thank you, Tim, for your presentation. I have a quick comment and then a question. First of all, I do want to comment because the city of Shawnee, we have co-responders and they're just fantastic. The police officers absolutely cannot say enough about the co-responders. So I want to say it works really well. So thank you for that. My second question is, do you follow like some of your clients? Like I've had, I've worked with like some people in aging, like an independent living or assisted living facility. And sometimes those are kind of like those people that fall through the cracks, right? Like maybe they have alcoholism or other problems. Do you follow those clients often, like people that go out maybe and visit them if they don't have transportation and things like that?
So
Thank you.
interesting enough, we really noticed that during the pandemic as volunteers were not able to like deliver meals, and we started delivering them ourselves, our staff. We saw way more isolation of that older population, older adult population. Again, then there's also older adults that are in settings that could benefit from mental health services. So last year, I proposed introducing a team, older adult team in 2025. We are in the process right now of hiring that team. And so I think we'll see, and I'll be able to give you some more statistics about what that is. But for example, we use that work with the co-responders, but we also work with the Shawnee Fire Department. So when they go out and do lift assist, then they can refer people back to us that maybe are living independently but are isolated, and this older adult team would pick that up and go forward with that. So it's an area of emphasis that we saw. We would not have been able to get that team approved if it was not for the CCBHC funding. The county approved it, and the state provided the funds, and so now we're going to be able to put that into place. So it's a true partnership.
Representative Reeves.
Hey, Tim, thanks for the presentation. Can you give us an update, and Representative Steens would be interested in hearing this too. The contract that used to be with Johnson County Mental Health with the county detention center, how that's gone through some changes?
Right. So about a year ago, we were asked to leave the jail by our former sheriff, Sheriff Hayden, and so that we had provided all the services in the jail up to that point in time. So that decision was made internally within his department, and so we left the jail. I had about 12 staff that were providing services 24 hours a day, 7 days a week in the jail, and doing reentry. So basically connecting with them in jail and then helping them reenter into our community. I suspect that well, actually, I already know that there's discussions with the new sheriff about what that might look like for us to start again. But that really had to do with medicating individuals over objection, and there's processes to do that. So we will continue to look at how we can serve our county. I do think that's the most effective way when you can have a community mental health center being involved with local law enforcement and be in the jails. So I'm hopeful that we get back.
That would be great. I know as, representative, we get calls from our constituents and emails, and I know that there was one time, probably a couple of years ago, that there was an issue of a parent whose adult child was in the detention center, needed medication, and she wasn't really sure how she was. Well, I was able to contact, your team and got a response, and I was able to tell the mom, there were some issues with HIPAA. We had to get, releases and everything to talk to mom and stuff, but, we were above board with that, and I was able to give mom some reassurance that her adult son was going to be helped by the mental health center, and it was just really helpful because I could do that. Yeah.
So I suspect the good thing is that that didn't happen on the juvenile side. We've continued to provide services within our juvenile detention center. In fact, we just opened in collaboration with them a youth crisis center in Johnson County. And so I suspect that within the next year we'll be back in the adult detention center.
Awesome. Thank you.
Yes.
Representative McDonald.
Thank you, Mr. Chair. Tim, I really appreciate you coming today. I have served the last several years on the Johnson County Mental Health Advisory Board, so I've had a pretty unique view into the work you do, and I'm really proud. I was trying to think about the future and what challenges that might be unique to Johnson County Mental Health. Do you have like a 5-year concern or a 10-year concern?
I don't know that I would say that it's a concern. I would say that there's opportunities. I think the key is providing access to care to individuals in the community where they live. So ultimately, as I've shared with our advisory board, my hope is that we are continue to expand under the CCBHC model, and I could envision us having 4 clinics that span across Johnson County down the I-35 corridor, which is where the majority of our clients live. So that would be in the Northeast office in Mission, in Shawnee at the 65th location, then in Olathe, which we're building a new building, and then we're getting ready to open a facility in Gardner. And so that would allow us to be able to have people would be able to access services locally within their community. And that's the whole point of community mental health, is for us to be in the community. So that I don't know that is a challenge, but it's also something that we look forward to doing. And I think through the CCBHC model, through the leadership of KDADS and the association and the development of our workforce, we'll be able to achieve that.
Very good, committee. Thank you.
Thank you
very much for being here, Tim. Next, we have Greg Hennon. And Greg, I'm not going to try to abbreviate, but if you kind of move it along, we've got
I will do
you,
that.
and then we've got the folks on the Behavioral Health of Excellence. So
very good.
Thank you, Greg.
Well, thank you, Chair, and the rest of the committee. I appreciate the opportunity to be here. My name is Greg Hennon. I currently serve as the Executive Director of 4 County Mental Health Center. We actually serve 5 counties in South Central and Southeast Kansas. About 86,000 covered lives across our catchment area. A lot of that is rural and frontier, but nevertheless, we have about 6,800 patients that we serve each year. And in representing an agency that was an early adopter of the CCBHC service model, I appreciate the opportunity to talk a little bit about how that model change has impacted our organization and those we serve. On the first page of my testimony, I'm not going to cover a lot of that. It's information that I had actually presented a year ago as kind of a snapshot of some preliminary outcomes with our patients. The reason I put that in my testimony today is I'm proud to say that those numbers that you see there, remain true today. So it wasn't just a fluke that we had some good outcomes out of the gate. When you look at access to services, 87% of our admissions are still happening the same day someone requests services from us. So we will schedule an appointment out beyond that first day when they request services. There's an average wait time of 3 days to get into our clinic. Now, if consumer choice is going to win here. If someone says, I only want to be seen on a Thursday at 3 o'clock, that may be a few weeks before we can get them into that time slot. But nevertheless, access to care has really skyrocketed. We've developed a lot of services that Tim just spoke about: mobile crisis, assertive community treatment, assertive outpatient treatment, veteran specialty, medication-assisted treatment for opioid care, in-jail services. That's something we do on a smaller scale than Johnson County, but it has had tremendous impact on the individuals that we've served, and the sheriff is one of our biggest cheerleaders by virtue of the work that we've been able to accomplish there. Something that's also, I think, changed quite a bit, and I don't have the statistics on the page, but I'll just share them with you real quick, is the coordination of care and integration with primary care. When people would come through our door, we might have had up to 50% of our patients that had an identified primary care physician. And now that we are doing some initial screenings for physical health conditions, we're coordinating with doctors' offices, we're referring them out so they can get a primary care physician of record. We're at 78 or 79% of our patients are also tied to primary care. So we're getting whole person attention to that individual, which is improving the outcomes as well. But my interest in being here is not just to highlight the positive impact of the patient outcomes that are being achieved. That's very important. But really to talk about the importance of the CCBH model on 4-county mental health center. You know, the CCBHC model was kind of born of an effort to modernize and reform the community mental health center system, the safety net system, and how it impacts through a continuum of care the state hospitals. We're treating a lot more complex patients than we used to. A lot of our mobile crisis, a lot of our ACT teams are identifying very severe patients that would not have normally come through our door, but they were in the community and they had pretty high needs in terms of their care, and may have been percolating to other people's attention like law enforcement or some other entity in the community. We're now able to treat those individuals through an earlier intervention and prevent a lot of the challenges or difficulties that others were experiencing. Now, in contrast, I will say that the 4 or 5 years before we became a CCBHC, 4-county and our entire system was really struggling. Kyle spoke to the fact that there was flat and maybe even some reduced grant funding for the uninsured in our state grants. Medicaid fee-for-service rates had been stagnant for 20 years. We had increase in uninsured coming through our door, which did not help the bottom line, certainly, but it was part of our mission, so we did it. But what we were doing is 4-county was essentially cannibalizing on itself to get from one year to the next. And what I mean by that is we would have some attrition, we would have some employees that would resign, and we would have a hiring freeze. We would not fill that position. We would take the money that was salary and benefit dollars from that individual's position, and we would just spread it across the remaining employees in the organization. We didn't give raises, we gave bonuses, because merit bonus is one-time money, right? So we were doing this for 3 or 4 or 5 years, and our organization was slowly shrinking as we tried to maintain the employees that were in fact staying with us. And after CCBHC, we were able to provide a more competitive, market competitive salary and compete with some school districts that had stolen about half a dozen of my therapists, and compete with Oklahoma that took about 6 or 8 of my therapists and half a dozen case managers. And we were able to kind of stem the bleeding there, if you will, from an HR perspective. When we look at previous years, our turnover rate was 18 to 24%, kind of depended on the season, okay? Last quarter, October, November, December in 2024, we had 5.5% turnover rate. So we're going from 18 to 24% down to 5.5 to 10% in our turnover. That is huge, especially when you're trying to recruit into a rural and frontier clinic, to be able to retain people and for them to have a sense of satisfaction. One of my last points here is that our ability to compensate staff was important, but it only tells half the retention story. When we look at the data-driven outcomes and we share those with our staff, you can tell that knowing they make a difference in the lives of the patients and having that objectively in front of them just lights a fire for their purpose, their mission in working for us. And every time we go to employee orientation and I meet with new people, I explain to them that Fort County does not exist so they can have a job, that we're here to the benefit of the community, and that it is a service organization. Well, as they conduct their service and they see that that makes a difference in people's lives, and it's a measurable difference, 82% of children have functional stabilization and improvement in 1 quarter of care with us. So across 90 days, 82% show benefit. 85% of adults show benefit in that same time period. So when our staff see that they're making a difference, their passion for the work we do increases. And when they have job satisfaction and they feel like their mission in life is being fulfilled, they want to be a part of our organization. And CCBHC made that possible for us during a time, like I said, we were cannibalizing on ourselves and shrinking. So that's been a lifesaver to the safety net system, in my opinion, and I thank you for all that you did to make that happen.
Very good, thank you. Committee, a few brief questions. Seeing none, thank you. Okay, next, Michelle, come on up.
Okay, good afternoon, Chair Carpenter and members of the committee. My name is Michelle Ponce. I'm here in front of you today in my role as Acting Director of the Kansas Behavioral Health Center of Excellence. I know you've all spent a great deal of time addressing healthcare workforce issues, and as you well know, the workforce shortage in behavioral health is particularly challenging, both for our community-based providers as well as our state psychiatric hospitals. At one time, Kansas was seen as a leader in the nation for behavioral health training and innovation. But when the Menninger Clinic left our state, we lost a lot of that capacity. To help fill the void and address those workforce needs, about 1.5 years ago now, we began planning for the development of the Behavioral Health Center of Excellence, and we had our official kickoff meeting just in December of 2023. It's been just a little over 1 year now, and we've made quite a bit of progress. The center is incorporated with the state of Kansas. We've established an advisory council and appointed a board of directors. We've adopted organizational policies and bylaws, and we have a pending application with the IRS for nonprofit status. Some characteristics of a successful center of excellence include access to the right expertise at the right time, the ability to develop actionable ideas and strategies, and building research and innovation to leverage existing resources. There are behavioral health centers of excellence in other states, though they may be organized a little differently than we are. For example, in Nebraska, theirs is housed within a university. Ours is not a brick and mortar institution, but rather a consortium of about 20 behavioral health providers and educators who've committed to this work. Our overarching purpose is to focus on innovative strategies to grow the workforce and increase access to care, as well as a longer-term focus on research and practice improvement. And we're striving to do that nimbly and to identify strategies that will have a real and a relatively quick impact. To date, we focused our efforts on the South Central Wichita area, and we chose this location for 2 primary reasons. 1, the number of committed providers from both higher education and the provider sectors, and 2, not the least of which, the impending new state hospital that will have its own staffing needs. It is our long-term goal, though, to grow and have a statewide focus in the future. In this 1 year, we've made a lot of progress, not just in developing the organization, but also in implementing some of those workforce strategies. Last year, the legislature appropriated $5.8 million to the Center of Excellence. Thank you for that support. That funding is already being used to support a number of educational programs and applied learning opportunities, all of which have been identified collaboratively from our advisory council. About half of that funding was dedicated specifically to nursing programs, which the lack of nursing continues to be a significant issue. So that funding was earmarked specifically for retention bonuses for nursing faculty at two-year community and technical colleges. In my written testimony, I've listed several accomplishments from this first year, and there are just a few I want to highlight. First are those nursing faculty retention bonuses. To date, we've provided funding to 19 community and technical colleges to cover 192 faculty members for just over $930,000. We also provided 10 scholarships in Wichita State University's addiction counseling program. Prior to offering these scholarships, that program had 0 students. This year, with the opportunity to offer scholarships, they had 14 applicants for the 10 scholarships, more than they even had available. On the final page of your testimony, I've included some testimonials from those students. What you'll find is a common theme of gratitude, a sincere passion for pursuing a career in this field, and acknowledgement that they would not have been able to enroll in this degree program without the funding that scholarship provided to them. We have members that are in the leadership of the social work program at Wichita State University. They've reported to us that just this year they've identified new internship opportunities with local providers that they didn't know even existed prior to working with the Center of Excellence, and they have now placed students with local community providers. Lastly, the University of Kansas in Wichita is in the process of expanding training fellowship programs in both child and adolescent psychiatry and addictions medicine, both of which are huge needs within the state of Kansas. Looking forward to year 2, we intend to continue those programs, and we also hope to expand support to additional priorities identified by our advisory council. You can find a list of those on page 3 of my testimony. Those in italics are new for year 2. To summarize them, they're largely focused on expanding psychiatric residency and fellowship programs and applied learning opportunities across multiple behavioral health professions, including social work, marriage and family therapy, physician associates, and addictions counselors. While we are requesting additional funding in FY26 for these items, we've also identified another potential strategy for leveraging state resources through expansion of the state's Medicaid Graduate Medical Education Program, or GME. That would allow us to draw down federal matching funds. We've already begun discussions with both KDHE and KDADS about this possibility, and both agencies have expressed support for the concept, but there is some uncertainty as how quickly it could be accomplished. Lastly, I want to add that we are using no state dollars to provide administrative support to the Center of Excellence. The Association of Community Mental Health Centers of Kansas has committed to providing the ongoing support and coordination to the center for however long is necessary to ensure success. With that, thank you for the opportunity to appear before you today, and I'd be happy to answer any questions you have.
Very good, Michelle. Thank you. Committee questions? Very good. Thank you very much. Next, we have Ken. Ken, welcome to committee.
Thank you, Chairman Carpenter. And members of the committee, it's an honor to be here with you today. My name is Ken Stoltzfus. I serve as the Vice President of Academic Affairs at Friends University in Wichita. And I'm also currently the Vice Chair of the Governing Board for the Kansas Behavioral Health Center of Excellence, or KBHCE, as we refer to it. As our Acting Director, Michelle Ponce just mentioned during her testimony, the KBHC was developed in order to address the severe shortages in the mental health workforce in Kansas. And I'm sure you all know this, but nearly all of Kansas qualifies as a federally designated mental health provider shortage area. And if you've looked at those maps, there's just not many spaces in Kansas that don't qualify as such. And of course, at the same time, mental health concerns and demand for treatment are skyrocketing. And even though I work in higher education, so this isn't always directly relevant to my world, I've seen this need firsthand. At Friends University, we operate a mental health clinic. It's staffed by our graduate students in our accredited marriage and family therapy program. And that clinic offers services both to our university students, but also to the community. And so, and the community members actually pay a reduced rate for services. We have a sliding fee scale for them. I've just seen over the past few years, our clinic's been stretched to the limit, and we've had to resort to measures such as implementing waiting lists and even telling some of our university students that they need to only receive a few free sessions in order to free up space for community members and other folks. In addition to my work at Friends, I'm also aware of the demand for mental health services because I serve on the board for the Wichita Salvation Army. I'm actually chairing that board this year. And I'm also on the board for the Mental Health America of South Central Kansas organization. And then in addition to that, before I taught, I was a social worker and then a social work educator. So come from this from a couple different angles. And I just say, in light of my personal and professional connections to the mental health field, it's just been an honor to be a part of the core group that's helped to start the KBHC over the past 15 months. This process has brought together 20 organizations, including mental health service providers, educational institutions, and state-level agencies. During the time we've worked together, I've been impressed by the commitment of the group to expand the mental health workforce in Kansas, and by doing so, to improve the mental health of Kansans. The expertise that's been mobilized by this committee has been truly impressive. Physicians, educators, and clinicians have worked side by side to address one of the most pressing issues facing our state. And as Michelle mentioned, the KBHC has already begun to make a difference, having secured and distributed funding to help retain nursing faculty, develop new educational programs to train future mental health providers, and provide scholarships and stipends to support current students who are studying to be mental health providers. During the course of my 30-year career in education and human services, I've rarely seen the kind of collaboration, shared vision, and collective dedication that I see at our KBHC meetings. As I'm sure you're aware, there's often turf battles, and we all sort of stake out our turf. I just have not seen that with this group. And because of the power of that collaboration, vision, and dedication, I'm convinced the KBHC is poised to make a difference in Kansas, both in the near term, as I've described, but also well into the future. The vision of the KBHC is that all Kansans will have access to timely and high-quality care, allowing our state to lead the way in access to evidence-based mental and behavioral health care services. The KBHC has developed a strategic plan to accomplish this goal by working towards 3 sub-goals or objectives. First, the attraction and retention of mental and behavioral health learners. Second, the enhancement and broadening of educational and training programs. And third, the promotion of system issue awareness and resource acquisition. As I mentioned earlier, the KBHC has already made significant progress on these goals during its first 15 months of existence, and I fully expect further success in the years to come. In closing, I just want to say I think the KBHC is an excellent example of the power and potential of American civic engagement. And that might sound kind of out there to say or kind of highfalutin, but I've got to say I've lived overseas for a couple years. I've seen other ways of doing things. I've seen other systems. And I've always been really proud of the U.S. Tradition of citizens organizing and working together to promote the common good. And that's just what I see happening at KBHC when we meet. I see a group of busy professionals who honestly are receiving nothing of material value in return for their work, who have banded together for the past 15 months to address one of the most pressing challenges facing our state. And it's just been an honor for me personally to be involved with this group, with this important endeavor. And I just ask you to continue to support the work of the KBHC as we move forward with our goal of ensuring that all Kansans have access to mental health services. Thanks again for the opportunity to speak today. I don't know if there's any questions that I can answer.
Committee, questions? Seeing none, thank you very much. And lastly, we have Tiffany.
Thank you so much.
Can you hear us?
I can hear you. Can you hear me?
Yes, we can.
Great. Thank you, Chair Carpenter and members of this committee. It's a really great honor to be before you today. And so thank you for this opportunity to speak to you. So I'm Dr. Tiffany Masson, president of Kansas Health Science University, Kansas College of Osteopathic Medicine, and I do strongly support the funding request that's before you related to the Kansas Behavioral Health Center of Excellence. As you all know better than me, Kansas faces a very severe shortage of psychiatrists, particularly in child and adolescent psychiatry, addiction, and geriatric psychiatry. The state has only 17 psychiatrists per 10,000 residents, falling well below the national average of 19.9. And there are only 69 child psychiatrists statewide, with most of them concentrated in Kansas City. And the rest of Kansas, including South Central Kansas, only has 12 psychiatrists for children and adolescents. And this shortage leads to very limited access, long wait times, and worsening mental health outcomes for our citizens, particularly in our rural and underserved communities. So KHSU in Kansas COM, as you all know, educates and trains future osteopathic physicians with a focus on behavioral health and community-based care. And we have partnered strategically with the Kansas Behavioral Center of Excellence to expand applied learning, programs in psychiatry, social work, nursing, and addiction counseling, only to name a few. And additional funding will help to support psychiatric residency programs, which we so desperately need, and creating a sustainable pipeline of behavioral health professionals for the reasons that I've mentioned before you earlier. This funding will leverage the federal Medicaid graduate medical education GME matching dollars to maximize the potential impact. It will also expand the training opportunities that will help to retain behavioral health professionals in Kansas for our communities. And strengthening the workforce will ultimately help to reduce long-term costs that are associated with untreated mental health conditions, which we so often see. So investing in behavioral health education for me is essential for ensuring access to quality mental health care. And Kansas, as you all know, and you heard from Kyle Kessler, has a legacy of leadership and mental health innovation, and this funding will continue that progress. So I urge you to support the Kansas Behavioral Health Center of Excellence, the funding request, and I stand before you for any questions in appropriate time. Thank you so much, Chairman.
Very good. Thank you very much. Committee questions? Looks like you're off the hook. Thank you again for being here.
Thank you.
Okay, committee, I think that wraps us up for today. I do want to mention again that we will be very busy next week. And so with that, we're adjourned.